I've divided my talk into two parts. I would like to review briefly the new data regarding droxidopa for the treatment of neurogenic orthostatic hypotension. Some of this data was already mentioned by Horacio Kaufmann yesterday. And in the larger part of my talk, I would like to talk about disease modification. So just a brief review of NOH therapy. Clearly, this is a combination of non-pharmacological measures plus drugs, including fluorocortisone, and sympathomimetics, including midodrine and droxidopa. So these are the two pivotal trials that came out last year and this year, and the combined data set led to the approval of droxidopa for the treatment of neurogenic orthostatic hypotension in the US. As Horacio Kaufmann pointed out yesterday, the data are particularly convincing for Parkinson's disease and pure autonomic failure associated with OH. The data regarding MSA are perhaps less convincing, but they also point towards efficacy of droxidopa in this disorder, and I'm going to review now a post hoc analysis just focusing on the MSA subjects. So the objective of these two trials was to assess the impact of droxidopa on the symptoms of NOH and activities of daily living using a new scale which is known as the OHQ, Orthostatic Hypotension Questionnaire, which comes in two parts. And I'm going to show you the data here concerning those two trials, just focusing on the MSA subjects. Both trials, the 301 and the 302, had an open-label titration phase to individualize the optimal dose for each of the patients up to 600 milligrams 3 times a day. That's shown here in both these studies. And this went on for about maximum 2 weeks. And in the first study, then the 301, there was a 1-week washout and then a 1-week double-blind using the OH questionnaire as a primary outcome measure. In the second study, patients were maintained for 1 week after the titration phase on open-label droxidopa, and then there was a 2-week double-blind washout. So there were 95 patients with MSA that were enrolled into the titration, and 56 were randomized into the double-blind period of the studies. There were about 26 patients, MSA patients, in the 301 trial and 30 patients in the 302 trial. The mean age and the distribution of gender is what you expect for MSA trials, as shown here. And the dosing ranged from 100 milligrams 3 times a day up to 600 milligrams. Most of the MSA patients actually required 600 milligrams 3 times a day. So this is the main result of the study, looking at, of this post-hoc analysis, looking at the OH questionnaire, which is the mean score of the two subscales. There was a significant improvement in favor of droxidopa, as you can see here. And this is then divided into the two subscales, the symptom assessment, shown here in the middle, and the daily activity scale. There is also a numeric improvement in the droxidopa arm compared to the placebo arm. This was not significant due to a strong placebo effect that was seen throughout the MSA post-hoc analysis. This shows you the individual items, the change in these items, and they all point in favor of droxidopa. On the left side, these are the symptom assessment items: dizziness, vision, visual disturbance, weakness, fatigue, concentration, head and neck pain, coat hanger pain. And these are the daily activities, standing for a short period, standing for or walking for a short or long period. And except for one of these items, all of these showed improvement, at least numerically, in favor of droxidopa. Interestingly, the standing systolic blood pressure also increased as a result of the droxidopa treatment, as shown here in the blue bars compared to placebo. And there was a correlation between the improvement of the standing systolic and the improvement of the OH questionnaire total and also some of the items. Now, the 302 trial, the second trial that was done, also had an extension phase which went on up to 16 weeks. And this just shows you the change in the OHQ, which is the blue line here. So there was an improvement seen here in the titration phase. And this was maintained throughout the open label extension. And this was also correlated with an increase in the standing systolic blood pressure, which was also maintained throughout the follow-up. So, sorry, this jumped back. The side effect profile was in general favorable. There were no significant differences between placebo and droxidopa treated patients. And importantly, one of the complications of anti-OH therapy, which is hypertension during the night or in the supine position, there was no significant difference here between placebo and droxidopa. So it appeared to be a safe intervention. So in summary, these data, although less strong compared to PD and PAF-associated OH, suggest that droxidopa could be an effective therapy for MSA, since it improved NOH symptoms during 1 or 2 weeks of blinded treatment. There was a greater improvement with droxidopa compared to placebo in most of the items in this questionnaire. There were improvements of standing blood pressure greater than for placebo and associated with or correlated with the subjective improvement of the symptoms. There were durable benefits that were seen in the open label phase for up to 3 months, and the side effect profile appeared to be excellent. Now, this is just a brief review of this post-hoc analysis concerning the MSA subjects. Clearly, further studies are needed for approval in this particular indication. Unfortunately, droxidopa so far is not available here in Europe. Now, I would like to switch to disease modification because this is clearly an area that has a great unmet need. These patients deteriorate in front of our eyes, and there is very little in terms of intervention so far that we can offer, or really nothing. So it's important to focus on this. I just want to review the completed trials that were done so far. The first one used recombinant human growth hormone because there was a rationale for this, in that growth hormone actually induces neurogenesis in various brain parts in various animal models. So at that time, that was about 15 years ago, Sirono decided to take this up and conduct a phase 2 trial with the EMSA study group. And so this trial shows the UPDRS that was before the UMSAS was available as the primary endpoint, change in UPDRS. 43 subjects were included in this trial, which was negative. But if you actually look at, if you actually look at the changes here in the UPDRS score, This is at 6 months, this is at 12 months. The black one is the verum group, and then the white bars here is the placebo group. You can actually see that there seems to be an attenuation of progression in the, sorry, this is always jumping, in the growth hormone treated groups, and the discussion was whether this is just a reflection, the lack of significance of underpowering this trial. So there were only 43 subjects, and there were only 30 study completers, so a high rate of dropouts, and this taught us a lesson. Obviously, these patients are often quite ill during the trial, and so this trial essentially lacked the power to demonstrate an improvement with growth hormone. The next trial, minocycline, this is the MEMSA trial, was based on preclinical data showing that suppression of microglial activation in animal models of MSA can actually lead to significant neuroprotection at the level of the substantia nigra. It can protect dopaminergic neurons. This is work by Nadia Stefanova in my lab. Here is the microglial activation in a transgenic mouse model, and we actually were able to team up with David Brooks in London to use PK11195 PET in a subgroup of these patients, showing microglial activation here in a patient at baseline, and this is under minocycline treatment. And you can appreciate the quite remarkable reduction of microglial activation that was seen here. A total of 5 subjects were on minocycline were subjected to this type of PET scanning. Unfortunately, the clinical endpoint, the UMSA's motor subscore over 48 weeks, the change of this showed no significant effect of this intervention on the disease course of MSA. Again, this could have reflected the fairly small number of cases here, 63, although formal sample size calculation was done for this, but it was probably just not sufficiently powered, again, to show efficacy. And maybe it also illustrates that even if you have a biological signal here, reduction of microglial activation in a patient with ongoing neurodegeneration, this may not lead to clinically meaningful attenuation of disease progression. Now, the largest study so far is the Riluzole trial, which was published in 2009, involving 400 subjects with MSA and 400 subjects with PSP. The main endpoint was mortality, and this was based at least partially on some preclinical data showing striatal protection with Riluzole in animal models of MSA. As you can see, the trial was negative. There was no impact on mortality rates with Riluzole, and all of the secondary endpoints, various types of scales, were negative as well. So whether that reflects the fact that glutamatergic mechanisms may not be so relevant in MSA is elusive to speculate. We just don't have enough preclinical data to back this up. So unfortunately, a negative trial. Another trial that was initiated in Italy based on lithium that had shown a reduction of alpha-synuclein deposits in animal models due to stimulation of autophagy was unfortunately terminated because of severe side effect issues. This trial had only enrolled 9 patients, and then it was terminated. It was a phase 1 trial. So basically, lithium doesn't seem to be a good candidate for intervention in MSA. Another large trial involved rasagiline. There was a pretty good preclinical rationale for this compound. Again, Nadia Stefanova in my lab showed that at high dose, this intervention actually led to protection of dopaminergic neurons here in the substantia nigra compared to sham. And also at the striatal level, there was protection that could be seen. The mechanism of rasagiline is kind of multiple. It works on the mitochondria. It reduces mitochondrial, or it improves mitochondrial function, reduces oxidative stress. Whether that is the key mechanism here in the model, we don't know. Based on this data, there was a global phase 2 trial involving 174 subjects. This was really with a solid sample size calculation. Unified MSA rating scale was used as a primary endpoint. The study went on for 48 weeks. It was a double-blind randomized controlled trial. And as you can see, the plots here shown the Verum and the placebo group, there was no change in the rate of progression using UMSARS. So basically, this trial was unfortunately negative. I should say that the dose used in this trial was 1 milligram a day, and Nadia Stefanova in the lab had actually shown that this intervention requires high-dose rasagiline, so the dose used here would correspond to 12 milligrams human dose, which clearly was not possible for safety reasons in the trial. So maybe rasagiline didn't have a fair chance to demonstrate efficacy in MSA. The next trial was a US trial led by Phil Lowe, phase 3, involving 100 subjects using rifampicin. There had been strong preclinical data showing that rifampicin can actually clear alpha-synuclein deposits in a more aggressive preclinical model using the MBP promoter to express synuclein in oligodendroglia. Sorry. Let me go back again. How do I go back? Sorry. Okay. Sorry about that. So there was evidence of reduction of synuclein lesion load in these transgenic mice. There was evidence of neuronal protection with rifampicin and reduction of astrogliosis. So it seemed to be a pretty good preclinical package of data suggesting that this might work. This trial was recently published in Lancet Neurology. Unfortunately, it was negative as well. The primary endpoint used the Unified MSA Rating Scale change over 52 weeks, the total score. Unfortunately, translation into a clinical scenario with MSA patients didn't work out in this trial. Now, another potentially exciting trial, actually the only positive one so far of the completed trials, used autologous mesenchymal stem cells, intraarterial followed by intravenous injections. This is a study from South Korea, and there were 34 subjects recruited into this trial, and they were divided into sham-treated and MSC-treated patients. And the primary endpoint, again, was the total UMSARS change, as shown here. And one of the secondary endpoints was the motor scale, the motor subscore shown here. And something that seemed to be happening in this trial after 6 months, so preceding intravenous injections of these stem cells once a month for up to 6 months, there was a separation of these progression plots. This is the sham-treated group with a steady progression, as you'd expect in MSA, and there was a reduction here, a clear separation of the total score and also of the motor subscore. The activities of daily living actually were not significantly affected by this. So this is an effect that these investigators detected on examination. There was less motor progression in these patients with an unclear benefit in daily life. There was also some additional endpoint surrogate markers using MRI, and here you can see atrophy in the placebo arm in these red areas here compared to the MSC arm where there is much less of this. And so these investigators propose that there is something happening consistent perhaps with neuroprotection. This is the only positive trial that we have so far. There are a number of issues and concerns with this trial, including safety issues. It clearly needs some kind of replication, and I will come to that in a minute. There is one other stem cell trial ongoing. Now, let's quickly review the ongoing trials. One is a French trial using fluoxetine. There is an interesting story that SSRIs seem to have an impact on alpha-synuclein clearance in various animal models, including MSA models. So this is data from Eliza Maslaya in San Diego showing this kind of effects, and he also demonstrated an improvement of trophic factor release, GDNF and BDNF, in this model. So the French network decided to test fluoxetine in 87 subjects. This was a phase 2 trial using the Unified MSA Rating Scale as an endpoint. So far, no data have been published regarding the results of this trial, so we need to wait for this. This is another trial with autologous mesenchymal stem cells ongoing at the Mayo Clinic. As far as I know, it's a single center trial led by Philip Lowe. They decided to take these autologous stem cells from fat tissue, expanded these cells and purified them, and they were injected intrathecally because the assumption was that intravenous systemic delivery may not work due to trapping of these cells in the liver. So they decided to go through the intrathecal route. 24 subjects, as far as I know, all of them have already been recruited, had baseline visit, had injection, and there is a follow-up, and it will take another year or so, 18 months, before we see the result of this study. Now, I would like to go on with a trial that is co-directed by our chair here, Professor Höglinger from Munich, together with Johannes Levin, involving epigallocatechin gallate, EGCG, which is a potent inhibitor. It's an extract of the green tea, a potent inhibitor of alpha-synuclein oligomerization. There are some in vitro and in vivo data showing this. This is a German network, essentially. The primary outcome is the Unified MSA Rating Scale Part 2. There are 86 subjects involved. There is a titration up to 1,200 milligrams per day in 3 doses, corresponding to 50 cups of green tea per day, and admittedly this is a huge amount that you need to see an effect on alpha-synuclein oligomerization. So this is a trial that is ongoing. The recruitment has been very good so far. We just need to be patient for the results now. Another compound that is interesting has been developed by AstraZeneca. It's an MPO inhibitor, and preclinical data have been published, 2 papers now. again with Nadia Stefanova from my lab, showing neuroprotection with this compound at the nigral level, but also in other brain areas, striatum, and also behavioral improvement. MPO is an enzyme that is overexpressed in Parkinson's disease substantia nigra in human brain tissue, but also in MSA brain tissue. It seems to have a relevance to the disease process, and if you inhibit this in animal models of PD and MSA, you do see protection effects. This study is a small study, it's a phase 2, essentially aiming at showing target engagement by using a PET marker to image microglial activation. So this work here relates to alpha-synuclein immunization. This is led by Afiris in Vienna, and there was a recent publication in the San Diego MSA mouse model by Markus Mandler and co-workers together with Eliza Meslaya, showing that active immunization against alpha-synuclein can reduce the GCI-like inclusion pathology. This is vehicle. Oh, sorry. So you see the GCI density here, and with the Afitope, which is that technology they use in Afiris to induce antibody formation, there is less of this, and you can quantify that in the neocortex. You see a reduction here and also here in the striatum. I don't have time to go into the details of how these Afitopes work, but this is all published work. This is now a trial that is running as a safety trial in MSA subjects as part of a EU consortium, SIMPAT, led by Vassilios Meissner in Bordeaux, using as a primary, this is phase 1, as a primary outcome adverse events, but there are a number of secondary efficacy outcomes that are also being looked at. So there are 4 injections as a basic immunization in 4 weekly intervals and 1 boost immunization 36 weeks after the first injection. There is a planned 12 months follow-up here. Whether alpha-synuclein immunization works in MSA is completely open. And needs to be settled. Clearly, alpha-synuclein load in MSA brains is much higher than in Parkinson's disease brains. So, you know, it's a challenge also for immunization therapies. But it is certainly an exciting new development. I would like to close with this slide here. The next MSA International Congress will be held in Salerno next year, April 21st to 23rd, and it will be organized by Paolo Barona and Maria Teresa Pellecchia. The website is already open. You could register if you're interested. And this is just to acknowledge my group in Innsbruck. Thank you.